episode of the Dr. Cliff Show. I'm Dr. Cliff Olson, audiologist and founder of Applied Hearing Solutions in Phoenix, Arizona, and I am joined with my co-host.
Hello, everybody. My name is Rachel Cook. I am also a doctor of audiology at Applied Hearing Solutions. Thanks for joining us today. We have a definitely long-awaited podcast episode about cochlear implants today. So we're starting this off. This is going to be a two-parter. It may even turn into a three-parter if things get really crazy over here, but today's episode is going to be focused on, first off, what is a cochlear implant overall? We're also going to be reviewing the hardware that goes into a cochlear implant processor, both the internal and the external components to that. We'll be reviewing some of the anatomy and what happens in the surgical process there as well. And then we'll also be reviewing some of the candidacy guidelines for who is or who is not a good cochlear implant candidate. So if you haven't already, make sure that you like and subscribe to the channel so that you never miss any part of this series or any other series for that matter. And if you have questions, be sure to ask them early and often. We do a Q&A section at the end. And if you've got questions that come up, definitely just let them rip. Kelsey is always ready to get those questions together so that we can answer them at the end.
Yeah, and like you said, we do have a pretty action-packed show today. A lot of graphics and stuff like that. So if you're thinking you're just going to listen to the show today, you might want to stop and doing whatever else you're doing and actually pick up your phone or your tablet or your laptop and actually watch it today, because there are going to be a lot of things that we're putting up on the screen that you guys should be following along with to make this stuff a little bit more easy to understand. We do spend a lot of time talking about hearing aids. Cochlear implants are a completely different animal. So when we're talking about them, sometimes it is helpful to have the visual representation of it.
Most definitely. But before we get into all of that, we're going to do our very first sponsor segment here, which is Eosera. Now, Eosera has an entire comprehensive lineup of ear care products: ear itch, ear pain, earwax MD. But I want to talk about something a little bit different today, because we actually had a patient call in yesterday and say, I took my hearing aid out of my ear and I can't find the dome. And we always tell our patients, if you can't find the dome, it's going to be best to come in and have us look, because chances are it may be in your ear. Now, it may have just fallen off, but regardless, we had to get that patient scheduled, have him come in, take a look in that ear, and make sure that it wasn't in there. So,
was it?
It was, but he could have noticed that it was in there himself if he had Eosera's EarView MD camera. So this isn't actually an at-home kind of a little video otoscope. It connects via Wi-Fi, actually, not Bluetooth, Wi-Fi, to your phone so that you can take a peek in your own ear and see what's going on. And you know what? If you're a hearing aid user and something like that were to happen, it'd be good to know if there was actually a dome in there or not. But also, if you're someone that produces a large amount of earwax pretty frequently and you don't know exactly when you should be going in to get that earwax removed, this would be a good way to check that as well, just to make sure, okay, yep, it's looking like there's a lot going on in there, or, oh, there's only a little bit, I can hold off until my next clean and check visit with my audiologist. So they have many, many more products than this, so make sure you visit eosera.com to look at their entire lineup. And if you use the code CLIFF20, you will get 20% off your entire purchase. So thank you, Eosera.
Awesome. Thank you, Eosera. So we got to jump right into what is a cochlear implant, because I would say most of the viewers of the channel, they probably are very familiar with hearing aids at this point, but this may be one of the first times that they're really hearing about cochlear implants. I only talk about cochlear implants maybe once a year on the channel, and so we're doing 2 action-packed, maybe 3 action-packed episodes on cochlear implants. But in general, when you think of someone with hearing loss who would use a hearing aid is designed to amplify sound to make it more audible so that sound can reach your brain, and then assuming that that sound is clear once it reaches your brain, you become a successful user of a hearing aid.
Yeah.
But what happens when you amplify sound? It goes up your auditory nerve to your brain and it's still not clear. It's louder but not clearer. That's usually when a cochlear implant is used. So basically, you do have a processor on the outside of your ear that communicates with an implant that is inside of your ear with an electrode array that goes into your actual cochlea, and you provide electrical stimulation to the auditory nerve, so you're bypassing all of the damage that doesn't allow you to hear clearly. And it's used in a lot of cases of severe to profound deafness and when hearing loss has progressed and hearing aids are no longer helpful.
Right. Now, of note with this, we're going to talk a lot about electrical stimulation today. I want to be clear, this is not an electrical stimulation that you feel. This is not like getting a shock or zapped or anything like that. This is electrical stimulation in the cochlea only, so just want to make that differentiation. So I think now let's jump into some of the actual hardware that goes into this, because there are a couple of components that go into this, both that are placed surgically internally, and then there are components that are on the outside of the skull. So we've got a graphic here, and we're going to leave that up for most of this discussion because we've got some pieces to point out here. So the first thing that I want to point out is on the far right-hand side of this picture, and it looks like a tiny little coil, like a little snail almost. And that is actually going to be the electrode array. This is what is actually being surgically placed into the cochlea and is being used to transmit signals to the auditory nerve and up into the brain. And depending on the type of electrode array that you have, just kind of depending on brand, which we'll get into next week, there may be 12 or up to 24 electrodes based on that electrode array.
Absolutely. And then at the very top of that, still on the right-hand side of the screen here, that is a magnet that rests underneath the skin. And that magnet is what actually receives the information from the coil that's on the outside of the skin, which is on the top of the left-hand side of your screen. That is what we call the processor as well as the coil. And so the processor looks, somewhat like a behind-the-ear hearing aid that you actually wear on top of your ear in this particular case. And that would receive an audio signal, convert it into an electrical signal, send it through the coil, and then it travels all the way through the rest of that system, providing those electrical impulses inside of the cochlea to stimulate the auditory nerve directly.
Right, so that processor is providing a lot of the power for both units, both the external processor, and then that power is getting sent through that coil to the internal magnet through electromagnetic induction, and that's how it's powering the entire unit overall.
And I do want to say that this is only one type of processor. There are multiple different types of processors out there that are designed in different ways. Some of them just look almost like only the coil that's on the top there at the end of that cord. For individuals who do not want to have something resting on top of their ear or who have very small ears and don't have enough room for that to sit on there.
Right.
But we'll be talking about different brands and things like that next week, so make sure that you guys tune in next week if you actually want to learn more about the different types of processors and the different brands that are out there.
Most definitely. Now, I think we need to get into some of the anatomy here because there is a lot that we need to review of why someone's hearing loss could progress to the point that hearing aids wouldn't be helpful anymore. And so we've got to start first with this idea of both inner and outer hair cells in our cochlea, our hearing organ. So we've got an anatomy graphic here. And okay, so up there, what we see, we've got the ear on the outside, obviously. We got the ear canal going all the way down to the eardrum. Then attached to that eardrum, you're going to see that there's actually 3 small middle ear bones in that middle ear space. And then attached to that is going to be that big blue structure there. And there's 2 main parts to it. That upper part with the loop-de-loops, we'll call them, that's going to actually be your balance system or your vestibular system. But next to that, you have that snail-looking structure, and that is your cochlea, and that is your hearing organ overall.
And that's why when you look at the end of that coil that's implanted, it has a little curl at the end of it because that's what actually curls around inside of that snail, which is your cochlea and your hearing organ. But inside of the cochlea, this is what we really, really care about here. The rest of the hearing system could be totally fine. The pinna, the outer ear itself, the ear canal, the eardrum, the middle ear bones, those could all be perfectly healthy and functioning normally. But it's what's happening inside of the cochlea is what matters. And we start looking at it from an audiologic side, we're looking at it from the perspective of outer hair cells and inner hair cells. Now, when outer hair cells become damaged, that is exactly when you want to use a hearing aid because those are the natural amplifiers inside of the cochlea. And so if those are damaged, you can amplify the sound externally with the hearing aid, and then the inner hair cells receive that vibration and send it up to the brain. But if your inner hair cells are damaged, those are the things that actually take that signal cleanly and pass it to the brain so you can hear and understand things when it's being amplified. Now, if those inner hair cells are damaged, and we actually have, let's go in with the healthy hair cells here right off the bat. So those are healthy hair cells. The bottom 3 rows there, those are your outer hair cells, and they're looking fantastic. And then up at the top of that picture there, that is the single row of inner hair cells. And let's go ahead and take a look at what they look like when they're damaged. All right, so you can see the outer hair cells there at the bottom. There's a lot of them just completely missing. And then the ones at the top of the screen, the inner hair cells, they do not look as clean as what they should be. Now, this individual here, if I was just to guess, this person is probably still a candidate for hearing aids, where most of the outer hair cells, there's still some there, but there's a lot of them damaged. And then the inner hair cells are at least still present in this particular image. But when we have this other graphic representation we're going to put up here on the screen, you're going to see healthy hair cells compared to damaged and then severely damaged hair cells. So you can see the normal hair cells there on the left. If they become damaged, they start looking a little bit gnarly, and then severely damaged ones, it's almost like they're gone completely with that.
Right, right. There's really not anything left there to send a nice clean signal up to the brain. So if there's a signal being sent at all, it's definitely distorted and it definitely doesn't sound good. So then we're talking about, okay, if you get a cochlear implant, what are we looking at internally and externally? And we've got a nice anatomy graphic here that shows what it looks like when we've got the actual processor here. And now, you know what, we may even just jump straight into the video here, because that's pretty helpful too. But what you see here, okay, perfect. Sound is coming and it's getting picked up by the microphones on the processor that are seated outside externally. And then that sound is getting basically digitally processed through the processor and getting sent up into the coil that you see blinking there. That coil is now sending that sound to the internal magnet that's then sending that signal all the way down through the electrode array and stimulating those specific areas of the cochlea and transmitting sound that way. And I think that lays a pretty good framework for kind of how this is working, because it is definitely a two-part system, more than a two-part system, but you need each component. You need the internal and you need the external for this to work.
That's right.
correctly.
I mean, in reality, when you take that processor off, because it's just a little magnetization over the top of the skin on your scalp, and when you take that off, I mean, it looks like you've had nothing done whatsoever, but you don't hear.
Right.
Like, you take that off, and it's like you have no hearing until you put that processor back on.
Yep.
And when you work with individuals who have cochlear implants, it's just as simple as them just popping off that little magnetic coil. They can't hear anything if you're trying to test them in their opposite ear or do something else, and then or comparing what things sound like left versus right. You can pop off the different coils and test that out. But it's a very interesting setup that is, as you can see, totally different than a hearing aid where we're actually putting sound through the ear. We are not putting sound through the system of the ear anymore. We're putting sound through the skin, basically, and then creating an impulse at the nerve, and then the nerve picks up these different impulses. Something that's interesting historically here is that the first person that got implanted with a cochlear implant, you were talking about anywhere between, 12 and 24 electrodes at the end of that coil.
Yeah.
The first cochlear implant had one electrode.
Goodness.
It was one single electrode. So they were just providing this, single stimulus. Who knows where on the nerve it was hitting? Because when you look at a nerve, it's, laid out to where different frequencies respond in different regions of the nerve. But to think that first person, when they really tested it out on that person, like, oh my gosh, I can hear. Now, it's not great.
No.
But when you can separate it out to 12 to 24 electrodes, and certain companies will probably be talking about next week, have these phantom electrodes where you can do like current steering inside of them and stimulate different areas along the auditory nerve. It's very impressive how they're doing this technology compared to actual hearing aids.
It is, definitely. And actual hearing aids, generally, nearly all hearing aids on the market are also going to have between 12 and 24 kind of frequency bands that you can go in and manipulate as well. So really, when you're looking at where the stimulation is occurring between a hearing aid and a cochlear implant, very, very similar in where they're stimulating. It's just how they're stimulating. Is it with actual sound or is it with just an electrical stimulus?
Yeah, and it really just depends, like we mentioned earlier, on the health of the inner hair cells. If you don't have any healthy inner hair cells, when you create vibration, even with the most powerful hearing aid in the world, it's not going to make a difference. You'd be like, well, I can hear stuff, I just can't make out what any of it is. And once you've reached that point, really, it's the inner hair cells that are not capable of taking that vibration cleanly up to the brain. So you have to bypass all of that stuff. We are literally, for lack of a better term, giving up on the auditory system, and
Yeah.
we're just going to go straight to the nerve.
Right.
Now, one thing we're not talking about today is an auditory brainstem implant, because some people are like, well, what happens if the nerve can't take the sound up to the brain? Well, I actually know someone who has an auditory brainstem implant where they actually do an implant on the brainstem, and you're bypassing that nerve. So I always tell people that, if hearing aids don't work for you, don't worry. There is another treatment option that will absolutely work.
Definitely.
And they all work to varying degrees, but once you've reached the usable capacity of a hearing aid, or once you've exceeded a certain level of benefit with a hearing aid, or not met that level of benefit that you want, really you have to go a different route, because you can't just keep expecting the newest, latest, and greatest hearing aid to solve your problem with that.
Definitely. And we're going to move into candidacy here after the next sponsor segment, and that's going to make a lot more sense as to why we would recommend that someone kind of give up on that acoustic stimulation and pick a different treatment route, an alternative treatment route, because as you said, there's plenty of them.
For sure. All right, so let's get into our next sponsor here. Now, if you have a severe to profound level of hearing loss, you might need a cochlear implant or a superpower hearing aid. But if you have a mild to moderate level of hearing loss, you might do okay with an over-the-counter hearing aid. So as of October 17th, 2022, over-the-counter hearing aids are now considered an official category of hearing aids by the FDA. And this means that you can purchase these devices online, and they are now regulated. So there are a lot of companies out there that are selling amplifiers and things like that, but now if they are an over-the-counter hearing aid, they have to meet certain criteria from the FDA. But you still have to be careful, because not all of these devices are created equal, which is why you should check out the Sontro over-the-counter hearing aid. The Sontro devices were developed by Soundwave Hearing out of Oak Brook, Illinois. They are a receiver in canal design, and the AutoTune app that you use to program the Sontro over-the-counter hearing aids makes it possible to customize your own audio settings, and this is critical if you really want to make sure that you're getting the most amount of benefit from these devices. You can learn more about the Sontro hearing aids at hearsoundwave.com, or check them out on my website, hearingup.com. I have done a review video on these that you can find on Hearing Up as well.
Okay, great. All right, now we're going to be moving into who is actually a candidate for these devices, because there has to be some sort of cutoff candidacy guidelines or criteria that goes into, are you a good candidate for something like this? When do I give up, so to speak, on hearing aids, and when do I move or consider a cochlear implant at that point? So what most audiologists are using now, and what I would consider the standard for cochlear implant candidacy evaluation referrals, is going to be this 60-60 rule. So tell us a little bit more about that.
So let's be really clear about this. This is not to determine whether or not you are a candidate for a cochlear implant. This is to determine whether you should be referred to a cochlear implant center for them to determine if you're a candidate for a cochlear implant. And so there's two main criteria with this. Number one is audibility. Number two is speech understanding. So when we look at audibility, we're looking at an audiogram, something the hearing test that you would have done by your audiologist or hearing instrument specialist. And if they determine that your pure tone average, which is the average of your thresholds at 500 hertz, 1000 hertz, and 2000 hertz, so the X's and the O's on that graph, if this number, if the average of those three numbers is equal to or greater than 60 decibels, then you are a candidate, you meet the first part of that particular referral candidacy, all right? Then we also have to look at the speech understanding. So this is your word recognition score. Now, these are the percentages that you typically get for repeating back single syllable words back to the person testing you. If your better hearing ear is less than or equal to 60% correct, then you are meeting the second part of that criteria to where you should be referred to a cochlear implant center for evaluation. That's why they call it the 60-60. 60 dB or higher or greater in audibility, and 60% or less in intelligibility.
Right. And I think you made a good differentiation there too. Not every single audiologist works with cochlear implants. Not every single audiologist is a cochlear implant audiologist overall. So we really are looking at a standard audiogram, a standard hearing evaluation with both pure tone threshold testing and word recognition testing to make this determination on whether a referral is then necessitated. And then they go on for a cochlear implant candidacy evaluation that's quite honestly about 2 hours in length. And if you ever go through one of these, make sure you eat a really good breakfast beforehand, because they're going to put you through the ringer. And really what I mean by that is just you're going to be listening for different words. You're going to be doing different speech understanding tasks, sentence understanding tasks, both in quiet and in background noise. So it's really just a large mental task during this evaluation. There's nothing really awful that's happening. It's not painful or anything like that. You just got to be ready to really use your brain during that evaluation.
Yeah, and I did my 4th year externship at a center that, half of it was cochlear implants, the other half was hearing aids. So I was exposed to both sides of that. And during these cochlear implant candidacy evaluations, we have to put you in the best aided condition. What that typically means is that we're fitting you with hearing aids and we're programming them to make sure that you do have ideal audibility of the sounds that you're going to be hearing during testing. So if you're not treated properly with hearing aids when you go in for this, that could actually be the reason why you got referred, is because you're actually not doing well with your hearing aids, and all you really had to do is have those hearing aids fit and programmed properly, and then you don't need a cochlear implant anymore.
Yeah.
But that's why we put you in the best aided condition. We take you through this additional testing. And really when we're looking for traditional candidacy with this, and we'll talk about this here in a little bit of what traditional candidacy means, it typically means that your insurance company looks at it like, okay, you've met the criteria. We as the insurance company are going to pay for the surgery and for the processor and the implant and all of that, right?
Right.
And so we're looking for that traditional candidacy, but you can be a non-traditional candidate for a cochlear implant. If you think of it this way, you could have completely normal hearing in one ear and be deaf in the other ear, and then technically speaking, your performance of your better hearing ear would remove you from candidacy because you do so well with it.
Right.
Well, I've had a number of patients who have been single-sided deaf, and they've been able to implant their deaf ear, and all of a sudden they've got speech understanding back on that particular side, but they're not a traditional candidate.
Right. That would be considered more of an off-label implantation at that point. But going back to this 60/60 real quick, these guidelines, we've got a research study, a graphic here.
Ooh, exciting.
Yeah.
Research studies. You guys signed up for this
We
today.
love it. But basically, this was talking about the development of a 60/60 guideline and trying to determine, okay, is this criteria too aggressive? Are we not allowing enough people into this pool and allowing them to go through the cochlear implant evaluation? Or is it too lax? And are we letting far too many people in to have these cochlear implant candidacy evaluations, and then they're just not a candidate after all? So in this study, they had 279 people total that met these 60/60 guidelines, and they referred them off, and they had them go through then this cochlear implant candidacy evaluation. And during that actual evaluation, 212 of them went on to become actual CI or cochlear implant candidates from there. So about 76% of those individuals became those traditional CI candidates. And that told us that this really was a pretty excellent screening measure to get more of the correct people referred on for this further testing.
And it's very important. You brought it up a little bit earlier, this idea that a lot of hearing care professionals that are out there that might not work with cochlear implants a whole lot or know when the right time to refer someone is, this is a very simple way for them to identify, you know what, at least I should be making the recommendation. Now, making the recommendation to a patient and referring them to a CI center is different than the person actually choosing to go.
Right.
I think this week alone, and I'm in the clinic, today's Wednesday, so 3 days this week, I've had to have cochlear implant conversations with 2 patients this week. And to where I'm sitting in the position of, I think that you've exhausted all of the reasonable benefit that you could get from a hearing aid.
Yep.
I think it's time that you need to go off and get a cochlear implant evaluation. And people are hesitant, right? Because there is a surgical procedure involved. It is not just like you go in, they pop it in, you're out. Like, there's a process, there's vaccinations that need to happen. If you have cardiovascular issues, you have to get it signed off by your cardiologist, for surgery or to actually go through the surgery. There's general anesthesia. Now, in my rotations, I not participated in because I wasn't holding a scalpel or anything like that, but I was an observer for probably a half dozen cochlear implants. And it's really, once you've seen one, it just becomes like it's not that impressive. And what I mean by that is that people undergo the surgery and you're like, that's it?
Yeah.
Like literally, like they cut you open, they drill a little hole, a little well through
Yep.
your mastoid bone, insert the electrode array, sew you back up, and it's like, okay, well that,
Was easy, pretty
yeah,
much.
yeah. I mean, I could do that.
Yeah,
Right?
okay.
Maybe
Well,
not. Yeah. Okay. Yeah. So, but really, I think that people are more scared of it than what they really should be when it comes down
agreed.
to that. But I also do think that not enough of us as audiologists and hearing instrument specialists are referring people
Right.
to go at least get the evaluation.
Right. And I totally agree. The 60/60 guidelines made it a lot easier for the widespread understanding of who could potentially be a candidate and who's not. Because you're exactly right. There were individuals beforehand or providers that were just wondering, well, maybe your performance on could be a little bit better, and maybe you still like your hearing aids, so we'll just keep going with that. There was this wishy-washiness of we don't really know exactly who's a good candidate. 60/60 made it so cut and dry. 60 dB PTA, 60% word understanding, boom. And then let the patient make that choice from that point forward. If they're like, oh, absolutely not, then you don't have to push it. You bring it up again a few years down the road and see if they've changed their mind. Otherwise, if you let them know about it, it's really just kind of empowering the patients to let them make that decision of, do you think that your performance with hearing aids is adequate enough, or are you looking for more?
And the fun thing about this, and I'm all about individuals, obviously the whole reason I have my channel is to educate consumers about hearing loss, hearing treatment, so they can make better informed decisions. The thing I love about this is that you could look at your own audiogram.
Yeah, oh yeah.
It's so simple.
It's
like
quick.
a 60/60 criteria. You average 500 hertz, 1000 hertz, and 2000 hertz. Add them together, divide by 3. If that number is 60 dB or higher, you met the first part, and then you look at your word recognition scores. If your better hearing ear is below 60% or 60% or below, then you've technically met that criteria, and you could theoretically take that, go into if you're not happy with how you're hearing, you could take that into your hearing care professional and say, hey, listen, and they probably already know that you're not doing well with hearing aids, and you could bring up, hey, I know that I meet this criteria, and you could request to go and get a cochlear implant evaluation. Now, some of them might say, oh, no, you're not that bad yet. But some of them would be like, if you're that dissatisfied with your hearing ability, let's get you into a cochlear implant center.
Right. So just really having the education more than anything. And quite honestly, that's why we do this podcast overall. It's just so people have the information to make their own informed decision about their treatment moving forward. Now, you spoke about this earlier, and we're going to move a little bit more now into who's a standard candidate based off of just the audiogram. So we're talking 60/60 guidelines, but just looking at the audiogram here, a standard candidate means that they would go on to then receive the more standard cochlear implant electrode array. And this would be that little coil that's fed in through to the cochlea, would span the entire length of the cochlea, helping both the low frequencies or low-pitched sounds and the high frequencies or the high-pitched sounds. So let's take a look at this graphic here for the standard CI candidate. Perfect. So you can see that this individual, if all of their X's and O's rather fell into that yellow region, then they're definitely going to have that pure tone average of 60 dB or worse if it's falling into that range. Anything to add to that one?
Yeah, I think that this is an important aspect too, because you start reaching a point where a hearing aid can no longer stimulate these really upper frequency ranges, and if you have some undetectable thresholds in the higher frequencies or any of those frequencies, even if your inner hair cells theoretically were still okay, you can't stimulate them enough with the traditional hearing aid to be able to reach that. So if you had X's and O's, your thresholds falling inside of that region, that would typically mean that you're a traditional candidate, or rather a candidate for more of a traditional cochlear implant that stimulates all of the areas inside of the cochlea, or as many of them as possible.
Right.
But then you have this hybrid candidacy. And so this is interesting because some individuals actually have some pretty good hearing in the really low frequencies. On the left-hand side of the graph there, you can see it goes all the way up to 0 up there at the top. But if you have a very steeply sloping hearing loss that cuts down through the center of that purple region and then down into the bottom right, that person person might actually do better with what we call a hybrid cochlear implant. So let me explain what a hybrid cochlear implant is. You basically have an acoustic component of this cochlear implant, so you're getting some amplification for the low frequencies, but then you use the electrode for the high frequencies. Now, surgeons have gotten really good at doing these surgeries to the point where they're getting cochlear preservation, to where even though they're inserting this electrode array into the cochlea through the round window, it is basically, they're still preserving some of the good low frequency hearing that you may have. And if you've had that preserved, then why the heck not stimulate it acoustically? And it's kind of like you're using a combination or a hybrid of a hearing aid and a cochlear implant.
At the same exact time, which is great. Now, someone also might look at that previous graphic of the hybrid candidacy and say, well, if they're hearing, at least in some regions, then why is a hearing aid not working for them? But those high frequency regions are so important for the clarity components of speech. And so someone with that type of hearing loss may have good environmental awareness of the things going on around them. If a door slams, if someone walks in the room or even starts talking, they might have awareness of that. The problem is, do they have any understanding of what's being said? And this is really where that hybrid candidacy comes into play, because yes, there is some good, perhaps even normal or even better than normal hearing in the low frequencies. But if you don't have access to those clarity components of speech, speech understanding is going to be pretty tough.
For sure. So we've talked about the traditional cochlear implant, the hybrid cochlear implant. Now we have to talk about this little bit of an offshoot, which I alluded to earlier with the case of single-sided deafness.
Right.
Because like I said, when you look at the traditional candidacy criteria, single-sided deafness is not technically falling inside of that. But fairly recently, within the past several years, the FDA actually came out and approved a cochlear implant for single-sided deafness, where you could actually get that implanted in your deaf ear, even if you have completely normal hearing in your opposite ear. And you know, it's one of those things where you would have to go in for candidacy criteria still, and then have a surgeon who's willing to do an implant of that. Now, I know for sure that one implant was approved for that, but I think that the different surgeons, they're more than willing to do off-label with certain other brands for single-sided deafness. And really here, if you have any pushback from your insurance company, what a lot of people don't realize is that the cochlear implant manufacturers, they have a team of people who will actually contact your insurance company and basically be on your behalf and negotiate to have them actually cover the cost of your cochlear implant.
Right. Right. So definitely has some high level support there. Now, you also made an interesting distinction there too, and I want to elaborate on that a little bit further. Depending on your age, surgeons will decide whether or not that single-sided implant is appropriate or not. And so generally when you're under the age of 2, you have to have profound hearing loss, and that means your X's and O's are at the very bottom of the audiogram. As we move more from the 2 to around 17, 18 years old spot, that's actually going to be more of that severe hearing loss, so they're a little bit more lenient with it. And then any individual 18 and above, that's when they start moving more to that 60 dB pure tone average thing as well. So it really does depend on age, it depends on your audiogram, it depends on, because you know, speech understanding scores, if you're a little baby, you don't have any speech understanding scores at that point yet, so they've got to use other kind of criteria to determine that.
Very true. And if you want to see some tear-jerking videos, I don't know, some people may cry, some people may not, but go watch those videos on YouTube where babies are having their cochlear implants turned on, and they all of a sudden they just light up and they can hear their parents' voices for the first time. It's just really moving. Yeah. I think it is anyway.
Yeah. So let's look at an actual example, top to bottom, of an audiogram, pure tone average, speech scores, all of these things, because I think it's really going to help lay the framework for what we're talking about here from start to finish. So first of all, we've got a copy of an audiogram here, and as you can see on the left-hand side, that's going to be your standard pure tone threshold audiogram. Over on the right-hand side, you can see there's a couple of other factors we're going to be looking at as well, such as speech and noise scores and PTA. There's that pure tone average we've been talking about throughout this episode. And down on the bottom, we've got a significant amount of word recognition or word understanding scores as well. So let's first take a look at that pure tone average. All right, we've got a red circle around it there.
And so technically speaking, this individual is meeting the first part of this candidacy criteria, because actually technically both ears are at or above 60 dB. And when you look at it, though, we're looking at the better hearing ear. So in this case, we would take a look at the left ear. That one is at 60, but again, we're still meeting the criteria there. So the next thing that we would look at is your word recognition percentages here. And so when we look down there towards the bottom of this screen, we can see that, well, in this case, the better hearing ear flip-flops. But even in this particular case, both of those ears are at or below 60% speech intelligibility. In fact, this person, when you put them in a binaural where they're hearing with both of their ears at the same time, they're not even above 40% in this particular scenario. So this individual would absolutely meet the 60-60 criteria. And the other thing I want to look at here is the QuickSyn score up there in the top right-hand corner. So anytime that we're testing someone in the clinic, we typically want to see how well they would do in background noise, and you want to get a very low score. The score goes from 0 to 26, closer to 0 the better that you do. This individual did above 15 dB on this, which puts them in the severe category. Now, with a cochlear implant, a lot of people will get benefit in a background noise situation as well, where they're not getting benefit from a hearing aid.
Definitely. But overall, looking at that, it's pretty clear that this is an individual who would technically be a potential bilateral candidate. Now, they probably would start with one ear over the other, and they'd probably base that consideration less off of the X's and O's and probably more off of the word understanding scores more than anything, because we saw that in the right ear it was 52%, in the left ear it was 36%. Put those ears together, you're scoring at 40. That left ear is actually dragging down the performance of the right ear and making the performance of the right ear worse. So to me, even though the X's and O's on the left side were better, the word understanding was worse, and to me that ear would be the first one implanted. Now, I'm not a cochlear implant audiologist, so that's just in my personal opinion, but all of these things are taken into consideration by cochlear implant audiologists who are making these determinations on the day-to-day.
And we're big fans of person-centered care, so having these discussions with our patients are very important. The individual who has an audiogram like that, you might be discussing all of this stuff and saying, hey, listen, you're a candidate, here's how everything works. The likelihood of you hearing substantially better than what you would with hearing aids is extremely high, and that individual could still be like, but I'm happy with my hearing aids. And I think that they work great. They allow me to do everything that I want to be able to do, and I'm happy as long as I use a remote microphone or something like that, an FM system. And that's fine. Like, we're not saying that you have to get a cochlear implant if you meet the criteria, or that you even have to go get evaluated. But if you're not doing well, if you feel like you're not doing well, that is what would prompt you to want to ask this question. And on top of that, there's no guarantee that if you go in, even with this individual, to go in and get, remember, it was 76% of individuals who met the criteria actually became traditional candidates, which means there's there is a percentage chance that you meet the 60-60, you're going for an eval, and they're like, sorry, you hear too well.
Yeah. Right. Oh, definitely. I have patients that's happened to them. And you know what? Honestly, at that point, that's good. We wouldn't have known otherwise, and they probably would have continued to think, could a CI help me to perform better? But what I also see is a lot of individuals who believe that they are CI candidates because they are not doing well with their hearing aids. And what we ultimately end up finding out is that their hearing aids are not programmed correctly, or they're not meeting manufacturer specifications, or. There's so many parts of comprehensive best practices that have not been followed in their treatment, and once we treat them at our clinic and take them through all of the comprehensive best practices, suddenly they're like, oh my gosh, I don't know why I was ever even thinking about a cochlear implant. I just needed my hearing aids set up correctly.
For sure, and that's why we started the Hearing Up Provider Network. So it's a nationwide network of hearing care professionals who are committed to following best practices. And, if you feel like you're not getting the most benefit that you should out of your hearing aids, or you feel like you might even need a cochlear implant, scheduling an appointment with a Hearing Up provider is definitely in your best interest, because if they see that you're meeting the criteria to get referred for a cochlear implant, they're going to recommend that you go get an evaluation for a cochlear implant and not just try to sell you the next latest and greatest hearing aid that probably still won't work for you.
Exactly. Huge differentiation there. So Okay, I think we've got one more sponsor segment before we start taking some questions.
That is right. All right, so I have the extended warranty discussion with my patients all the time in the clinic. Most hearing aids come with a 1 to 3 year warranty and loss and damage insurance. If we can't fix your hearing aids in the clinic, we can send them back to the manufacturer. They will fix them at no additional charge, as well as if you lose your devices or damage them beyond repair, we can get a new device coming in for just the cost of your deductible. However, most hearing aid users keep their hearing aids for 4 or more years, and when you start looking at it from that perspective, you're going to be uninsured and unwarranted for a certain period of time, and that's why you need ESCO. ESCO specializes in providing loss and damage and repair insurance coverage for your hearing aids, so you do not have to pay for expensive repairs or buy new hearing aids before you're ready. Their Protection Plus plan covers loss and damage and the warranty on your devices outside of your manufacturer's warranty. They have a variety of different coverage plans that you can get a quote for your exact hearing aids on their website. If you go to esco.com/Dr. Cliff, Dr. Cliff Show viewers get a $10 Visa gift card just for registering your hearing aids. So thank you, ESCO. All right, well, it's questions time now. I'm wondering how many of our viewers were interested in this episode, since we talk mostly about hearing aids.
Quite a few, actually, and there were a lot of people who are using hearing aids that are wondering if they are, in fact, cochlear implant candidates. So we've got quite a few questions to get through. Okay. The first is actually more an anatomy and physiology question. Just as a clarification, this person writes, I'm not completely clear under normal circumstances as to where the inner hair cells and the outer hair cells start. Also, where moving outward from the ear canal to where the outer hair cells end, could they please clarify on what that actually looks like?
All right. This is going to be some clever explaining. So, as you're traveling through the auditory system, and I don't know, Chris, if you can put up the ear anatomy up on the screen that has that blue cochlea on it, this might help with the explanation. So as sound enters through the ear canal, it will vibrate the eardrum, send that vibration through the 3 middle ear bones, and then into the cochlea, which is that blue coil that you see there. At the entrance of that blue coil, that is where the inner and outer hair cells start. So they both kind of go in alignment with themselves all the way through to the very end. So when we look at the entrance, that is where the higher frequency regions are coded for. So the inner and outer hair cells there are creating vibration along what we call the basilar membrane in the high frequency region. And then as you go deeper and deeper into that coil, you eventually get to the lower frequencies. But you literally have inner and outer hair cells coiling around the entire region of that cochlea, and I'm hoping that that answered the entire question.
I'm hoping so too. It's hard to be on this side where we know exactly what we're talking about, and so hopefully that breaks it down enough for better understanding. This next question is, I was always told that the implantation process will strip any residual hearing. Now, just in the last couple of days, I'm hearing differently. Can you please clarify?
Did they get an implant?
They did not get an implant, currently using UP hearing aids from Phonak.
Okay. So traditionally speaking, back all the way when they did a very first cochlear implant with the one single electrode, yes, they were honing the technique in, the surgical technique of inserting that electrode array. And what actually did end up happening in a few cases was that the technique was kind of going in and damaging some of those inner hair cells that in that lower frequency region where they may have had some better hearing still, and leaving the individual with, yes, you take the implant off and they would be fully and completely deaf on that side, put the implant back or put the processor back on, and then you can hear again. Nowadays, though, the surgical technique is so good that they have had much better success in preserving any of the residual hearing that's left. And what we generally mean by that is just more often than not, the low frequency hearing that may still be in somewhat of a good range, and only doing that electrical stimulation in the mid to high frequencies from there.
Yeah, and it's becoming more standard practice to when someone goes through their cochlear implant surgery, even before they activate them with their processor, which is, depending on where you go, a week to a month after your implantation date. they're actually doing a sound booth test on you to see, okay, what are our thresholds now? Because if we happen to preserve any of them, maybe we do want to convert this from a traditional to a hybrid. Because I've actually seen that happen where you get the full electrode array installed, and then they're like, actually, you've got some pretty good low frequency hearing still. We're going to stimulate that acoustically and at least see how it goes.
Yeah. I've seen the audiograms where they show the pre-implant versus post-implant, and there's some really, really just surprising ones where the pre and the post look identical. It's like,
that's crazy.
It's like their hearing has been preserved entirely, except now we can stimulate those areas that just were not able to transfer acoustic signals previously.
Yeah. Excellent. So we've got one more question to address here. I have sensory neural hearing loss, but I still have difficulty understanding my family when they're talking to me, and I'm always wearing my hearing aids. Could I need a cochlear implant?
It's possible.
Definitely possible.
What I would say is that most people do get their audiogram from the hearing care professional or have a portal that they can log into to look it up, or they can call and request to have it sent, and most clinics will send it to you. And you could actually look to see what your word recognition scores are, what your pure tone average is, and like I said, you might be able to see like, oh my gosh, I'm falling within inside of this candidacy region of where I should be at least referred to a cochlear implant center to get an evaluation. But I would say, like you were talking about, Dr. Cook, earlier, the higher likelihood is that you are not optimizing the performance of your hearing aids. Now, I want to be very clear with this here. I think it is very important for every single person with hearing loss to understand what their hearing loss is and if they are actually getting the full amount of benefit from their devices. You should know that.
Yes.
When you are done with a fitting sequence or you're working with a hearing care professional, they should explain that you are at your highest level of hearing capacity with these devices, and we know that because we've measured and verified everything along the way.
Yep, definitely. I mean, like you said, you should know at that point. And I would wager too, if you don't know if your audiologist is following best practices, if you're wondering what are these best practices that they keep talking about all of the time, like that probably should have been dropped a couple of times throughout your course of treatment. You should know that your provider is following them. If they're not following them, there stands a chance that the devices themselves are out of specifications. And we see that all of the time. Literally every single day we see devices that are outside of specifications. That right there, having that fixed and having that remedied, could make a huge difference in your performance. If that's not it, like you said as well, taking a look at your audiogram, seeing if you're falling even close to these candidacy guidelines. If you're not falling close to these candidacy guidelines, there is a strong chance that it is simply how your devices are programmed for you. And if they're not programmed for you correctly and they haven't been verified or validated along the way, then you're of course not going to be doing well with them in hardly any circumstance.
And it almost, I think I heard from that question, it's like when they're around family. I imagine maybe multiple family members talking, and maybe you're fine when you're one-on-one, but if it's multiple people talking, that's maybe where the problem is coming up. You really need to know your speech and noise score.
Yeah.
Like if you have a high speech and noise score, 10 decibels or higher of signal to noise ratio loss is what we call it in the profession. But if it's higher than 10, chances of you being able to function in that environment, even when your hearing aids, the best hearing aids in the world, are programmed perfectly, you're still going to have some trouble there, and you need to use like a remote microphone in that situation or some type of Roger system to hear them better. Now, if you have a very low score on that and you're not hearing in those group situations, it means that you're probably not programmed to your full prescription, because there's studies out there that have been around since, I think, 2012 is my favorite study, that shows that an analog hearing aid not programmed to your prescription, an analog hearing aid programmed to your prescription will outperform a digital modern hearing aid that is not programmed to your prescription when you go into background noise. So it is very important to know if you've had real measurement done, like you mentioned, and that your hearing aids are programmed the right way. Because if they're not, you're going to think you're a cochlear implant candidate when you're really not.
Yeah.
Well, and here's the thing, too, is that on hearingup.com, we also have the best practices checklist. Print it out. Take it to your provider. See if they're actually following these steps. And if they're not following these steps on their own, ask if they can be followed. And if not, there is also a Find a Provider tool on hearingup.com where you can find someone in your area who does follow these comprehensive best practices. And so there are resources available to make sure that you are getting comprehensive treatment. So I think that that's important too. Again, also, if you haven't had your hearing tested since you got your hearing aids and it's been more than a year, high likelihood that even if they were working for you well at one point, not meeting specs, no longer meeting your prescription because perhaps your hearing has changed. So making sure that you are also staying on top of that and advocating for yourself in that fashion as well.
Absolutely.
Okay, that is all the questions that
awesome.
we have.
Well, hey guys, thanks for joining us today. We always appreciate when you take some time out of your Wednesday to watch us. We are here live every Wednesday at 4 p.m. Arizona time. Of course, you can find us on YouTube Live, Facebook Live, and WTSMTV.com. And as always, we'll see you next week.